Coverage through Medicaid. We've expanded coverage through Medicare. Health insurance companies around the country, including Blue Cross, just today announced that all of their members will be waiving all co-payments on coronavirus treatment. But for those some 30-odd million uninsured Americans, the president has directed the coronavirus task force to find a way to make sure that they know we will find a way to pay for your coronavirus treatment, and the president will be addressing that and announcing that tomorrow.
Mr. President, a point of clarification and then a follow-up question. Yesterday you said that you spoke to Florida Governor Ron DeSantis before he issued his stay-at-home order. Did you advise him to issue that order?
No, but I talked to him about it. And he wants to do what's right for the people of Florida. He's been a great governor. You could see that just by his popularity, which is extraordinary. We're proud of him. He's done a fantastic job, and he made the decision. But we spoke before he made the decision, yes.
And he had also said that he is considering putting people who are suspected of having coronavirus or who have tested positive for it in isolation centers, and that he could So he hasn't consulted with
I haven't heard that. Yes.
Thank you, Mr. President. Ebony Bowden from the New York Post. A few hours ago, Mayor de Blasio, the mayor of New York, said that New Yorkers leaving their homes should wear masks. They should also wear masks when they're with other people. Are you considering that kind of recommendation on a federal level? And if you are, how would you prevent a rush on N95 masks?
Well, I think they're going to be coming out with regulations on that, and if people want to abide by them, frankly, I don't think they'll be mandatory because some people don't want to do that. But if people wanted, as an example on the masks, if people wanted to wear them, they can. If people wanted to use scarves, which they have, many people have them, they can. In many cases, the scarf is better. It's thicker. I mean, you can, depending on the material, it's thicker. But they could do that if they want. Now, a recommendation's coming out. We'll see what that recommendation is. But I will say this, they can pretty much decide for themselves right now.
Nationwide, and can I also
nationwide,
not just for hotspots, and then maybe this is best for Dr. Birx, but we've heard some differing guidance here. The WHO, even the Surgeon General, have talked about various studies that show that masks, in addition to maybe not even being helpful to protecting people, may actually increase the rates of illness because people touch the masks and they touch themselves.
Sure.
Can you talk a little bit about just the evolution of thinking on this?
Dr. Birx. And you might mention that other point also.
Yeah.
No, thank you. So I hope you got from the conference today that we're triangulating data that we know from the case numbers, the testing numbers, the supply chain numbers to create an integrated picture so that we can really support hospitals in their needs. And I think that level of granularity is really critical. Secondly, I just want to make the point that we really applaud the governors that are looking at a whole of state or a whole of metro approach. And what do I mean by that? The United States, going into this, had about 160,000 ventilators across the United States and another 60 to 70,000 anesthesia machines. That's about 5 times what most of the European countries have. But it's a matter of distribution to need, and I really applaud the governors that are bringing together their public hospitals with their more private hospitals and their visibility across their state. Because what we tried to talk about yesterday is every state, every county is different. That's why we're looking at it at that level of granularity. And as we move through this epidemic, the needs need to be very tailored to those counties and frankly those hospitals. I mean, there's a reason why the president and Mr. Kushner have been very much involved in finding out what the public hospitals need. Why is that? Because the public hospitals sometimes have the weakest supply chain because they're often sometimes not as attractive to private sector distributors, or they may be too busy caring for the needs of patients to be really on top of their order forms and their supply chains. So really listening to the community that's at the front of this fight and getting feedback from those specific communities, no matter where they are, and listening to the frontline healthcare workers, because it's their reality that is important to all of us, whether you're the mayor or the governor or the federal government. And if they're saying they need something, we have to work together to supply that. And so that's what you're seeing with this triangulation. Every county will move through this differently, and that allows us to move around these vital issues that protect the frontline healthcare workers and protect the patients through the ventilators to make sure that the supply chain is aligned with the need as it happens. Now, you have to have very good data in order to be willing to work in that level of granularity, and that's what we've been working on to really develop that level of granularity to ensure that. So I just wanted to say one other thing about testing, just to give you the bottom line data of what we're seeing. We appreciate the groups who are reporting. Not everyone is reporting yet. And this is part of us trying to understand at a very granular level. We do have 2 states that do have 35% positives, and that's New York and New Jersey. So that confirms very clearly that that's a very clear and important hot zone. Louisiana, though, has 26% of their tests are positive. Michigan, Connecticut, Indiana, Georgia, Illinois, so that should tell you where the next hotspots are coming, are at 15% test positive, and then Colorado, DC, Rhode Island, and Massachusetts are at 13%. There's a significant number of states still under 10%, every one that I didn't discuss. California and Washington remain steady at an 8% rate. So what we're seeing finally is testing improving, more testing being done, still a high level of negatives in states without hotspots, allowing them to do more of this surveillance and containment. And then prioritizing this new rapid test kit to those areas that may not have the same amount of access to the Indian health services and to the public health institutions and the public health and state labs, so that they can use that and start forward leaning into surveillance. Now, we know that our people waiting for tests, and they're waiting for tests because when these areas became when they got onto the logarithmic curve, we prioritized people whose decisions, where the test decision would make it critical for their care. And so we prioritized hospitals, and we prioritized nurses and doctors and frontline workers. So that means if you went through a drive-through or you went through your doctor, you could have that delay. So the masks. So what I tried to give you is how we're using data in a very granular way. And so there's experiential data. When you look at communities that have oftentimes utilized masks in general for personal protection from when they particularly are themselves sick and have used their mask in public. And we've looked at the rate of this COVID-19 in those populations. And then we're looking at the scientific evidence to bring those 2 pieces together. Let me just say one thing though. The most important thing is the social distancing and washing your hands. And we don't want people to get an artificial sense of protection because they're behind a mask. Because if they're touching things, remember, your eyes are not in the mask. So if you're touching things and then touching your eyes, you're exposing yourself in the same way. So we don't want people to feel like, oh, I'm wearing a mask, I'm protected and I'm protecting others. You may be protecting others, but don't get a false sense of security that that mask is protecting you exclusively from getting infected, because there are other ways that you can get infected because of the number of asymptomatic and mild cases that are out there. And so this worries us, and that's why the debate's continuing about the mask, because we don't want, when we're trying to send a signal that every single person in this country needs to stay 6 feet away from everybody, that needs to be washing their hands constantly and know where their hands are, to send a signal that we think a mask is equivalent to those pieces. So when the advisory comes out, it will be an additive piece if it comes out, rather than saying this is a substitute for. And we want to make sure everybody understands it is not a substitute for the presidential guidelines that have already gone out, and to be absolutely clear about that.
Quick question about the test, folks. There's a lot of evidence we're seeing that experts are saying that a high number of these tests could be producing false negatives. So,
Of the Roche and Abbott tests?
that as many as 1 in 3 tests might be providing false negatives. I was wondering maybe you could
That
explain
would almost
about
be
the science.
impossible with having 35% positives. if that was true, you would have
Yeah,
100% positive or 66% positive. So what I can tell you is the number of positive tests is tracking very closely with the number of cases diagnosed. So I will look into that. I look at the Roche and Abbott numbers every night. They're trending exactly in the same way, and that's important when you're validating data to really validate, does this same site, in other words, I'm looking between testing sites to see, are there consistencies? Is there an anomaly? To make sure for what you just very specifically asked. So I will go back and look at it more carefully. I haven't seen that kind of anomaly. This same platform is being used across the country, and that's a range from what I reported, 3% positivity up to 35% positivity. And that range reflects also what we're seeing with the hot spots and the number of cases. And frankly, I mean, we hate to talk about it, but it also tracks with the hospitalizations independent of diagnosis and the mortality that we're seeing. So all of those pieces validate together.
That people might be getting a false sense of security, or that we might not be seeing all of the data here on who has it.
Well, I'm telling you, I'm still missing 50% of the data from reporting. I have 660 tests reported in. We've done 1.3 million. So there is, and it could be those sites. So we do need to see, the bill said you need to report. We're still not receiving 100% of the tests.
Dr. Birx, with regard to the test, the president's sample collection took 1 minute, results were reported back in 15 minutes. I realize you're the president of the United States, but when will everyone get to take a test that works that quickly and you get results that quickly?
So these are new tests, and we have prioritized the groups that we think have the least access to testing now. And who do we mean by that? We mean the Indian Health Service. They're often in remote areas, rural areas, the governors of the northwestern states that may not have the advantage of these high throughput machines that are often across the East Coast and in high metro areas, Colorado, and then across the West Coast. So we've prioritized the presidential 15-minute test to the Indian Health Services and public health labs so that they can support nursing home testing and other areas where we think surveillance is absolutely key. So at this moment, they're prioritized in that way. Yes, 1,200 of them are going out in that way.
More of those tests need to be made in order for
They
more
are
people.
being made.
Yeah. Okay, so in a matter of,
They're moving very quickly.
So I'm glad you asked that, because today, there's 18,000 of these machines already out there. We're trying to find out exactly where everyone is, because you can see that gives you amazing flexibility. Because if people would allow it to be loaned to a state that's in a hot spot or a state where you want to do additional surveillance, 18,000 tests, 18,000 machines is a huge amount. And it really gets to your very question about how we can prioritize what we have at the same time we're moving out what is new. And so really figuring out who should those go to, who can we ask communities, because these will be in the community, to share those machines into the community who need the testing now. And I think that's really an incredible question that really needs to be answered over the next 24 hours.
Dr. Birx, the point of clarity about the face covering guidance, you said it's still a point of debate. You said to use the phrase the guidance if it comes out. Is the guidance coming out, and when?
Yes.
And when, sir?
In the days ahead, we're currently working through the task force, taking the consultation advice, CDC, our top health experts, and
I'm Brett Baer in Washington. The president's coronavirus task force briefing will continue online. We are stepping away at the end of the briefing for a special town hall with Martha McCallum, which will start right after a short break. Now, Sir Winston Churchill once said, if you're going through hell, keep going. I'll end this show with an adjustment to that. As the sun sets tonight, we are one day closer to putting this all behind us. We're all in this together. Thanks for inviting us into your home tonight. Fair, balanced, and still unafraid.
Excellent job. Travels with the Stephensons, glad to bring you this information. And because when anybody questions what the president has said, or the vice president has said, or the team says, there is a good record here of the tape to prove the point.
The rumbling dark, so come a little closer.
And a lot of the
Give me something
negativism is stuff that's made out of or things that are taken out of context and used in a negative way.
Feeling like the person people meet really isn't us. Like we're gonna buckle underneath the trouble. Like any minute now, the struggle's gonna finish us. And then we smile at all our friends. Even when I'm weak and I'm breaking, I stand weeping at the train station, because I can see your faces. There is so much peace to be found in people's faces.
Love of Jesus.
I love.
Bring a smile to their faces. We're never lost if we can find each other. If you need help or can afford it, Facebook.com.
Tonight, a worldwide pandemic with no end in sight.
We will be extending our guidelines to April 30th to slow the spread.
Thousands of Americans dead, hundreds of thousands more sick.
This can happen anywhere, and that's really one of the issues that we're concerned about, and why we were so reluctant to pull back at a time when we need to put our foot on the gas as opposed to on the brake.
More than 3/4 of Americans ordered to stay home.
There is no American who is immune to this virus.
Fears of unemployment at all-time highs as parents take on the job of teachers with their own jobs on the line.
I hate to see the numbers jump. I don't think anybody's terribly surprised.
Now, more than ever, the American people are looking to their leaders for answers.
So I say, my friends, that we go out there today and we kick coronavirus ass.
Tonight we'll be joined by the men and women on the front lines of this fight to hear you, to guide you, and to remind you that we are all Americans.
Amen.
And we are all in this together. Good evening, everybody. I'm Martha McCallum, coming to you from Fox News headquarters in New York City for this virtual town hall. Tonight, we are partnering with Facebook in a commercial-free hour to bring your COVID-19 questions straight to the men and women who are on the front lines of this fight, including 2 members of the White House COVID-19 task force, Dr. Deborah Birx and U.S. Surgeon General Dr. Jerome Adams. Of course, here at Fox News, we are practicing social distancing, so every member of our audience will be appearing through Portal from Facebook, a device used to connect family and friends across this country. Everybody is using all of this video conferencing as we experience this together. Fox News and Facebook also proud to announce tonight that we are making a joint donation of $1 million to Feeding America's COVID-19 Response Fund. That money will help food banks across the country as they support communities who are impacted by the pandemic. With that, let's get started. Let's bring in our first guest tonight. Very pleased to have Dr. Deborah Birx, White House Coronavirus Response Coordinator, joining us. Dr. Birx, thank you so much for being here this evening. You know, one of the quick questions that I want to sneak in before we get to Patrick is this question of, of a couple of weeks of total national lockdown. What would be the difference if we did that compared to where we are right now?
So we know from the countries around the globe that really enforce their stay-at-home policies have really flattened the curve. We see it happening in Italy, we see it happening in Spain, and we think that is incredibly important. It's why the president put out the guidelines. Those are guidelines for all of Americans, speaking directly to Americans, past their local governments and state governments to say, please understand you need to stay home.
But no national lockdown, nothing that's more severe is being recommended by you and the force right now?
Well, we're a United States, and the states have priority in taking care of their citizens and understanding what their citizens need. I think the president's made it very clear that the way to stop this virus is to do everything that's on those guidelines, and that includes not having parties in your house, not going to parties in other people's houses. You see the reports coming out of New Jersey and other places. Just being in the company of others with a level of asymptomatic carriers, that you can become infected when you gather together and you don't maintain 6 feet distances.
All right, so that's the word from the top, and asking for really national compliance and leaving it up to the state governments to decide if they are going to push it further than that. Let's get right to our first question, Dr. Birx. This is from Patrick O'Brien. Patrick is one of the people in this country who has lost someone to COVID-19. Patrick O'Brien, thanks for being with us today, and we're so sorry for your family's loss, sir.
Thank you, Martha. Thank you for inviting me. Yes, my brother lost his life to COVID-19 last week, and his wife is still in hospital, but seems to be recovering. And they're both in their mid-30s, so I understand that this can hit people not only of older age that we keep hearing about. It can also hit people of other ages. So, thank you. So my question, however, is about a still younger group, as I'm concerned about my own children. I know that a few children have had severe cases of COVID-19, but my question is, among the minority of children that have had severe symptoms from COVID-19, has that correlated with a history of other respiratory issues like asthma or bronchiolitis?
Well, that's a really great question, and thank you for asking it. And I feel for your family and the depths of these losses, and to still have someone in the hospital struggling with this disease is very difficult. We know from the studies around the globe that there is a direct relationship between how serious this disease is and age. But we also know that this is the first country that this virus has come to where we have a lot of what we describe comorbidities. And if obesity and if asthma and these other diseases that the United States struggles with are part of the pre-existing conditions that may make you more susceptible to a worse outcome, we will see it uniquely in this country. And these are the reasons we're tracking this very carefully. Certainly we learn from other countries, but we don't know precisely from the United States. And you are absolutely right. There will be individuals in the United States that have a more serious course. We do still believe strongly that the severity is related to age and pre-existing conditions, but it may also uncover a pre-existing condition that many of us didn't know existed. And that's why we've asked everyone in America has to be responsible for following these guidelines, because you don't know if that person you pass on the street, in the pharmacy, in the grocery store, is susceptible to having a very bad outcome. So protect yourself and protect other Americans.
Patrick, thank you so much. And again, our sympathies to your family, and we wish your brother's wife well as she continues to recover from this. You know, doctor, you just said someone that you pass on the street, and I think the outside transmission is a question that's on a lot of people's minds. If you want to go outside and go for a run and you want to exercise, what's safe, what isn't safe, and should we all be wearing masks outside? That's a two-parter.
Yeah, I think that's really important. I think we believe, and I think social distancing is absolutely key. We also want Americans to be able to walk their dogs. There's a way to do that responsibly. There's a way to maintain that social distancing. I see in Washington, D.C. all the time now, people being attentive to that, and even crossing into the street if there's no cars coming, to really ensure that they're giving people those 6 feet space. We know in cases where you have to be less than 6 feet, whether that's a nursing home or whether that's a pharmacy, and certainly our doctors and nurses and all of our frontline providers, we know in order to keep them safe from exposure because of their closeness to others, that they should be wearing masks. And so that's really an important piece. We're still talking about the importance of masks potentially, or some kind of face cover for the general public, and getting data that is coming in from Singapore Singapore and other countries. We're looking at that very carefully, but of course, you know, Hong Kong and Singapore are very different lifestyle from the United States, different level of density of people than in the United States. So we're trying to understand, do face coverings play a role in the general public? And I think it's very active discussion within the task force.
Okay, let's get another question. This is from Eden Alva.
Hi, my name is Idan Alva. I've been a Lyft driver for 5 years now. My question is, as a Lyft driver, what risks am I exposed to while driving passengers? How do I mitigate these risks? And how do I approach and what do I do with people who display signs of illness?
It's on a lot of these drivers' minds, Dr. Birx.
Yeah, that's important. And to all of the people who are Lyft or Uber or other informal driving situations, making sure that you cut down on the number of passengers in your car, making sure that you're distanced within your car. There is a way to get almost 6 feet away from an individual in your car if they sit on diagonally in the back versus back in the front. Really utilizing that information to keep yourself safe. We really appreciate what you do. We appreciate what all the workers are doing to ensure that people that are essential workers are getting to their jobs every day, and we know you're a critical part of that, so thank you for what you do. But we really want to also ensure that you are safe, and I think really maintaining as much social distancing in your cars is possible. Certainly increasing air circulation would also help.
All right, I have a question for you about the incubation period. You know, I think now that we're at this stage of this process, people, you know, learn that someone has it who they might have been with 2 weeks ago or 3 weeks ago. What is the incubation period, and how, you know, how much have we learned, or has it changed over the course of this, Doctor?
Well, you know, all of this is dependent on symptomatic cases and finding them. And we all believe that there's a greater proportion of people who are asymptomatic than recognized. And again, that may correspond with age, with greater number of asymptomatic cases in people under 40. And so both severity of disease increases with age, but asymptomatic potential may also decrease with age, so that it's more in the younger age groups. And so we believe that there could be significant transmission from asymptomatic individuals. Now, the incubation period, we all know what the median is. So the median is about 1.5 days. The question is, how broad is that curve that defines that 1.5 days? We've heard as early as 1 to 2 days, and we've heard as late, because there's always, in science, there's always the outliers. So you're always interpreting data at the 99% range. So the data that's out there by CDC, the 2 to 14 days, that really includes the 99% range. But you can always find that outlier at 21 days. So it's never 100%. And so right now it's still median of 5.1 days, but it does expand between 2 and 14, and there may be 1 or 2 outliers at a 0.1%.
So in some very rare situations, it could go as long as 21 days, is what I'm hearing you say.
Correct.
Okay, let's get to another question. This is Jeff Gallagher from Wisconsin. Thanks for being here tonight, Jeff.
Hi, Martha. Thanks for having me. My question for Dr. Birx is, I saw reports from some countries in Asia that coronavirus survivors are testing positive again. Is there any truth to this? And what can this information tell us, if so?
Thank you. We're seeing those same reports, and thank you for staying aware of this virus and looking across the world, and we really appreciate the internet that is able to share that information. But remember, those are anecdotal cases, so in the general population of individuals that have been studied, as people get well, as people produce antibody, which protects the individual from the virus returning, they are developing the ability to clear the virus, and that includes being able to not measure it any longer in their nose. Again, as in all science, there's a bell-shaped curve. There's a bell-shaped curve to recovery. Not everyone recovers at the same time, and there'll be a bell-shaped curve to your ability to continue what we call shed virus from your nose and your mucous membranes.
Thank you very much, Jeff. Jeff brings up Asia and the question of the data that we got from China. You said the other day, Doctor, that there was missing data that caused scientists like yourself in this country to read the data that was there and think that this was a smaller situation, something that was more SARS-like in nature. How damaging was that early release of information and still all of the holes that have not been filled in from China?
Yeah, I appreciate you raising that. At the time when this virus struck, many of you know I work on global health, HIV, TB, and other diseases around the world. So I was working very intently on HIV at the time and was overseas in sub-Saharan Africa watching the data coming from China. And I think when we looked at the profile, first there was a question about human-to-human transmission. Obviously in a virus, that's really key, because if there's not human-to-human transmission, it stops with that first sets of transmission. So there was that first question. And I think when you're in the midst of an epidemic, it's hard for you to really be testing at the level that you need to really look for those asymptomatic cases and really look for those people with mild disease. And so now we're finding out that most of the reporting was around very severe cases that presented in a very difficult situation, and that they weren't really measuring asymptomatic or mild disease. In that case, that may be a significant portion of the epidemic, and so we didn't know how it was spreading, we didn't know the surface contact, we didn't know how, I think the bottom line is we didn't know how contagious it was. And I think when you make misassumptions around contagion early on, then you don't prepare in the way that you should prepare for the level of contagion that this COVID-19 exhibits.
Dr. Deborah Birx, thank you so much for taking the time away from everything that you're doing to answer some of the questions of the people across the country, and we look forward to the next briefing and all of your work. Thank you very much, Doctor. Good to see you today.
Thank you.
So joining me now is Dr. Amish Adaya, Senior Scholar at the Johns Hopkins University Center for Health Security. We were just talking with Dr. Deborah Birx about the early information that came out of China, which has been called, in her words, missing data. How much of a problem was that in terms of the early harnessing of this virus?
It's definitely been a major setback in responding to this pandemic, because we didn't know in the beginning what the case fatality ratio is, what the spectrum of illness was, who was getting sick, who was getting mild cases. All of that made it very hard to actually outbreak response. And now we're seeing that there were data gaps, and a lot of stuff was handled in a way that we didn't think was actually being handled that way. For example, not counting asymptomatic cases. So most of what we've done in other countries has been based on that early Chinese data, and if that data was bad or not complete or misleading, it's going to influence everybody else's pandemic response, and it made things harder not knowing if we could trust that data completely.
Yeah, according to reports, our U.S. intelligence says that it was intentionally incomplete. So obviously, that adds another layer to this. But we want to stick to the medical side of what we're looking at here. And we have a question from Corrine, who is in Milwaukee, Wisconsin, for you, Doctor. Hi, Corrine.
Hi there. Thanks for having me on.
Thank you.
My question is, an MIT professor recently came out saying that pathogen-bearing droplets from sneezes and coughs can travel up to 27 feet and suspend in the air for up to 10 minutes. With that in mind, is the social distancing recommendation of 6 feet far enough?
Great question. Doctor?
So what I think about I think that in most ordinary circumstances, 6 feet is ample distance to keep between individuals. There are obviously experimental studies that can show, just like the one at MIT did, a longer trajectory of these particles, but we're not seeing the epidemiology that supports that being a major way that people are getting this. We're seeing people getting this from people that they're in close contact with, not 27 feet away. So even though there may be theoretical possibilities there, that's not really what the everyday transmission of this virus is like, where we would be in a different place.
Thank you so much. Thanks for being here from Wisconsin this morning. Let's go to Corey Carr, who has been recently furloughed. Corey, thank you for being here today. What's your question for the doctor?
Hi. When do you expect that people will return to work? And when we do, would you expect to see a spike in cases again?
Good question.
So I think that what we're going to see is probably layered layered types of decisions to allow certain people to go back to work. And right now we're seeing governors looking at the list of what is essential and what is non-essential workers, and that's being modified as we get through this. I do think that this virus isn't going to go anywhere, so when we do relax social distancing, we're going to see more transmission occurring. The question will be, will that transmission be at a level low enough that it doesn't exceed our hospital capacity? That's the main issue, is trying to keep the number of cases occurring at a speed and a density that our hospitals can handle. And when we do relax these restrictions, we're going to see more cases, but they're going to probably be in a setting where the hospitals are much better prepared to handle them.
Corey, thank you very much. Thank you. Thank you. Thanks for being here. So, Doctor, you had talked about the balance between getting people back to work and the health of the economy and the health of American people, that as it relates to that versus the devastation of this virus. And since we had that conversation, the numbers have obviously escalated dramatically. How do you answer that question now at this stage of the game?
I do think this has to be something that's put into the models and put into the decisions that governors are making, trying to understand what the right balance is so that we don't let this virus spread uncontrollably and overwhelm our hospitals on the one hand, but we actually try and quantify and understand and minimize the risk that's going on from people losing their livelihoods, people putting off other medical conditions. I know people, for example, who can't get a breast cancer surgery because it's considered elective. I know people who are really not able to go to their psychiatric group therapies because they're considered against social distancing, and I've seen a psychiatric patient decompensate for that. So there are all of these costs that have to be put into the models. The models are great, they're useful tools, but remember, they don't include everything, and we have to think about all of the longer-term consequences that we'll see down the road, and we have to strike the right balance. But with controlling this virus, increasing hospital capacity on the one hand, but thinking about how we get out of this, how do we move to the next phase so that we don't cause damage with our control measures. And it's a very hard decision to make.
Very hard indeed, and one that I know our leadership is going to struggle with mightily, and it's very important. Last question before I let you go, because we're going to talk about this in the next block, but I wanted to get your opinion on it as well. If you had COVID-19 or a loved one had COVID-19, would you recommend to them that they ask their doctor for dosage on hydroxychloroquine and azithromycin combination? Would you recommend that to a family friend or member or friend?
It all depends on the patient. I have prescribed hydroxychloroquine to more than one patient. Those have been hospitalized patients that have pneumonia. We don't know what the role will be in mild patients, so a lot of hospital protocols are basically restricting it to those who have been hospitalized and have pneumonia. So I think it has to be on a case-by-case basis. If somebody is at high risk for complications, I do think there may be a role for hydroxychloroquine. I haven't used it in combination with azithromycin yet. I may in the future, but it is still important. At the same time that doctors are prescribing this, that we actually study this in randomized controlled trials so that we actually have data going forward to know whether or not it's effective. But it is something that I do think about in every patient that I treat.
Very interesting. Dr. Amish Adala, thank you so much. Great to see you as always, sir. Keep up the great work. All right, it is a race against the clock and the globe to find treatments for COVID-19. My next guest is a scientist who has been working very hard to do just that. Dr. Jacob Glanville is the founding partner and president of Distributed Bio and is a computational immunoengineer, and he joins us once again from his lab. Great to have you back, Doctor. What can you tell us? How can you update us on the treatments that we're hearing about? What is most promising out there, and when can people get it?
Hi, Martha. Thanks for having me back again. So yeah, there's basically three categories of treatments. There are repurposed medicines like chloroquine that was just mentioned, and there are ongoing studies that are going to give us updates on exactly how effective those are. There are vaccines, which are going to be very useful, but we're talking about potentially 18 months out before they're available.